Professor Lindahl, what were your first thoughts when becoming aware of the Big 8 results?
The first thoughts were actually that I was impressed of that this study could be performed in a randomized way, and also that I was also impressed of the results of the big difference between the experimental and control arm regarding the number of patients that could be discharged from the ED, and that also tells me that the people at the emergency room really followed the protocol.
How can a specific rule-out concept improve patient management in the ED?
Yes, I think another strength of this study was, of course, that they really tested a specific rule-out protocol with criteria defining a non-AMI. And this is, I think, a novel approach that will make it possible to identify the vast majority, or categorize the vast majority of patients already on admission as AMI or non-AMI, leaving only a small proportion that needs further evaluation. So a specific rule-out protocol can certainly make a big difference in the turnover time of patients in the ED.
Is Copeptin an essential part of this concept?
Well, we know that the usual way we do this with a troponin on the 99th percentile is not enough. So we definitely need something more. And I think still it's an open question whether it should be Copeptin, as in this trial, and that trial showed convincingly that it works. But there are also other alternatives that need to be evaluated, ideally compared with this, like having a very low cutoff of troponin, or a 1-hour rule-out protocol, or combining with a risk score. I also think it's impossible not to forget that that clinical evaluation must be an essential part of all these protocols.
Do you think these study results will attract physicians to explore and use Copeptin together with troponin in routine, as it will be implemented in the Charité in Berlin?
Yeah, definitely. I think the results are convincing that this rule-out strategy can really speed up the rule-out in the emergency room, and in many EDs, this is a very important question. So, of course, having evidence from a randomized clinical trial will attract a lot of physicians. I'm pretty sure of that. And at least to explore whether this is applicable in your own institution. And also, hopefully, to initiate studies comparing different methods, different approaches for ruling out.